joining. We'll get started. We'll get started with announcements, just give everyone another minute to hop on. So you may have been here when the slides were showing, but we have a few announcements. The next lecture series after this one is on the 22nd about lean and green healthcare. So that'll be super interesting. Another exciting event that's coming up, sponsored by SMCI, is the Lean Academic Healthcare Conference here at Stanford. It's September 10th through 12th. Registration is open now, and we really encourage you to apply. We're really excited. It's the 10th year, the 10th annual Lean Conference, and Selena is just putting the event information in the chat. So please consider taking a look or joining us in September. There's also a funding announcement. The Lilly and Donnelly seed grants are happening now. Applications are open, and you can find more information, again, also on the SMCI website, on the Lilly and Donnelly seed grant program page. Those are awards of $25,000 for smaller programs and up to $100,000 for larger programs. And all the details are on the website, along with how to apply and all that fun stuff. But I think those are all the announcements I have today. So I'm really super excited for today's presentation from Katie Smith and Dylan Thomas on collaborative care, engaging patients and families, and quality and safety initiatives at Stanford Health Care. So I'll give a little bit of a bio of our speakers. We'll hop into the presentation, and then we'll get started with a Q&A session at the end. So briefly, Katie Smith is the manager of the Volunteer Resources Department and the Patient and Family Partner Program at Stanford Health Care, where she leads initiatives to enhance patient and family engagement through a dynamic volunteer program. She has extensive experience in volunteer management and is dedicated to improving the patient and family experience by fostering collaboration and meaningful connection between volunteers and the healthcare community. And we're so excited that Dylan Thomas is also joining us today. So Dylan has been a volunteer at SHC since 2020. He currently sits on the Patient Safety Committee, the ADA work group, and chairs the Disability Patient Family Advisory Council, as well as serving on the Emergency Department PFAC. He's been a patient at Stanford since 2005, and he's passionate about all things healthcare because he has chronic illnesses that result in regular visits to the hospital and some extensive allergies that put him at risk in environments that don't have a solid safety culture. So really emphasizing that need for a solid safety culture. And I'm so excited to hear what they have prepared for us today. So as mentioned, they're going to kick it off with their presentation, and then we'll have a Q&A section. If you have any questions during the presentations, feel free to put them in the chat. I'll make sure that we loop back to them at the end of the presentation. So without further ado, Katie and Dylan, please take it away.
Thank you, Cassie. It's a great introduction. I'm just going to pull up my slides here. Okay, hopefully you all can see this all right. Okay, thank you. So good afternoon, everyone. That was a really great introduction. So I don't feel like I need to introduce myself, but I'm Katie Smith. I'm the manager of Volunteer Resources and the Patient and Family Partner Program at Stanford Health Care. I'm really excited to be here today with Dylan Thomas, who, as you have heard, is a volunteer with our Patient and Family Partner Program. And we're here today to talk about how our program really enhances the patient experience through collaboration with patients and families. So here's a little overview. We're going to talk a little bit about our program. Then Dylan and I will share some specific examples of how the Patient and Family Partner Program has really worked to improve the patient experience efforts across the organization. You see, we'll have plenty of time at the end for questions. And so I'm going to jump right in and talk about what is the Patient and Family Partner Program. So as you can see here, it is a volunteer program, and it is housed under the umbrella of the Office of Patient Experience. So the Volunteer Resources Department, as you see here, oversees a couple of different things. First, we oversee our general volunteer opportunities throughout our hospital and clinics. So things you might think of like a front desk volunteer or a gift shop volunteer. We also oversee our Pet-Assisted Wellness at Stanford program, or PAWS, our pet therapy program. And then finally, what we're here to talk about today is our Patient and Family Partner Program. So as you can see here, there are two components of the program, which I'll share a little bit about momentarily. But first, just wanted to share, what is the goal of the Patient and Family Partner Program? The goal is to bring the voice of patients and families into all work aimed at improving patient care at Stanford. So our patient and family partners lead improvement work. They focus on projects that they have identified as most meaningful, and they do that through our patient and family advisory councils. They also participate in ongoing improvement projects across the organization through what we call our patient and family partner engagement opportunities. So we are really here to lean on their experiences as patients and caregivers to ensure that the work we do is always patient and family centered. So what does that mean? Patient and family-centered care is an approach to planning, delivery, and evaluation of healthcare, and it's grounded in mutually beneficial partnerships among healthcare providers, patients, and families. So this approach really does redefine the relationships in healthcare and places an emphasis on collaborating with patients and their families. So we really want to collaborate. We want to make sure that we're moving patients from a role of consumer of healthcare to an actual partner, someone who is participating fully and has the ability to make decisions regarding their care. And why does this matter? Of course, it's the right thing to do. But other than that, it also brings value to the organization. So we know that when we partner with patients and families, we see improved outcomes in patient and family satisfaction, improved outcomes in quality and safety, additionally, improved outcomes in staff and physician engagement. And these things can lead to things like increased revenue, our reputation gets better, we see decrease in costs, so there's less waste, less error, etc. So it does just make sense. So as I mentioned, there are two components to the program, and the first is probably what we're most known for, and that's our Patient and Family Advisory Councils, or our PFACs. A PFAC is a forum for communication and collaboration between staff and patients and caregivers. It's really meant to be led by patients and caregivers. So this isn't a program where we have staff members coming in saying, you should work on XYZ. This is really an opportunity for our patients and families to come in and say, this is what we've experienced. This is what we think is important to patients at Stanford, and these are the areas that we want to focus on. So they participate in monthly meetings. They may also do some offline work depending on what those goals are, but they set 3 goals every year. Each goal may be something like an improvement goal for the PFAC themselves. So maybe they want to learn as a group how to become better storytellers. We might have them complete a training so that they can make an improvement within their PFAC. We also ask them to set what we call a community goal. So that's a goal that really focuses on the community of patients and families that they are serving. So you can see in this photo, this is our heart transplant PFAC. Their community of patients is heart transplant patients. So they're doing work to really support that community. And then finally, we ask PFACs to set a service line goal. So this is really looking at the service line to each area or department that they are involved with and figuring out how can we get involved in the goals that the organization already has set and make sure that we are including our voice in the work that's happening there. Each PFAC has a chair that's a patient or a caregiver that's been nominated by the council, and they also have a staff advisor. So that's an employee at Stanford Health Care who helps to facilitate meeting logistics, and they act as an advisor. You can see here we have 9 active patient and family advisory councils. We will be adding a 10th council for our Tri-Valley system in fiscal year 26, so we're excited about that. And then I'm going to move on to a couple of PFAC accomplishments. I'm not going to go into too much detail here, but just want to point out that we have a couple of things on our fiscal year 24 kind of year in review. We had 115 patient and family partners as part of our program last fiscal year. They reported 3,400 volunteer hours, although we know this is consistently underreported, so this should probably be a little bit higher. And last fiscal year, we had 11 active PFACs. We had 3 of our cancer center PFACs actually merge into one. So they are now kind of what we call a super PFAC, and they kind of launched in 2024. So PFACs last year, they held a variety of education events. They put on symposiums, town hall sessions for patients and caregivers. They also they designed newsletters that were sent out to patients and caregivers across the organization. These newsletters were really beautifully designed. They had helpful tips. They talked about things that were new and different at Stanford, also included articles written by some of our clinical providers. So they had a lot of useful information for our patients and caregivers. And another example is our PFACs participated in a variety of improvement projects. So one example is our emergency department PFAC. They partnered with the My Health team to help increase usage among patients in the emergency department, and also proposed a series of enhancements to the app for the ED. So those are some examples. And I'd like to now turn it over to Dylan, who can share a little bit about the work that he has done as part of his PFAC affiliation. So Dylan.
Dylan, thanks for having me. I just short bio myself. I already got introduced, so I won't spend too much time on this. I think one phrase that I consistently say that I've been saying for years is I don't have an MD, I have a DD, Doctorate of Dylan. Sort of moved here in 2005 for my dad's job. So started off at Packard, and now on the adult side for majority of my care. I probably average 50 to 70 nights a year inpatient for various things. Part of, I think, sort of what I think I advertise well for myself is I'm not in necessarily one sort of area. I see a bunch of clinics and have been to most of the units on 300 and 500. Photography is my passion. As you can tell, I'm having pictures taken of myself, so I usually have a side view for my profile. And I sort of got initially involved in probably 2017, 2018. I was on B3 after ankle surgery, and my health back then, that was B3 was the test unit. And so I got to help beta test sort of the my health inpatient feature. Did a couple more projects with them specifically, and then became an official family and patient partner in 2020. Next. So I am on two of the PFACs. One, which is associated with the clinic, is the emergency department one. That one I've been on since 2024. Sort of, I think one of the reasons why I was interested in joining is I probably average at least one visit, if not more, a month for various reasons. And so sort of get to see a lot of the ED and sort of be able to identify what's good, what's bad. And so joined that about a year ago. Really enjoy it, just rank a member, which I also like. I do get to sort of serve as the patient voice and the patient rep for the monthly customer service steering meeting, which is where they have all the departments that are involved, translation, labs, radiology, basically anyone who touches the ED sort of all together. And I get to act as the patient voice and bring it back to the ED PFAC meeting. And sort of also with that, I am also on the patient voice and patient rep for the My Health registration work group to sort of streamline the ED registration process. I still am able to bring my own voice views with someone with disabilities, many of them. I can't unfortunately turn that hat off and not have them. So I sort of am fortunate that I still get to represent sort of the disability aspect in the ED PFAC. And then because of that, and sort of one of the first things I did when I became a family partner was I was on the disabilities PFAC. It got started in 2021. I think it sort of got started, if you know SMCI, which I'm not even going to pretend I know what the abbreviation is, but Dr. Peter Poulos, he sort of wanted to have a patient voice and sort of representation better. And so I think he sort of, for a couple of years, had been working on it and finally got it launched in 2021. I have been the chair since 2023, so a couple of years now. And I think sort of the biggest thing that I like to say as sort of the chair, obviously I run the meetings and help set goals and stuff. That's boring stuff. I think my biggest thing is sort of to make sure we have a wide representation of disabilities on the PFAC, because we have probably 10 to 15 members. Probably 10 of them are patient and caregivers, and probably have 4 or 5 staff members. And so with only having a select few patients and caregivers on it, it is important to sort of make sure we're not sort of being siloed of, oh, we're only seeing this disability, and make sure we hit, okay, do we have things that affect people's mobility? Do we have things that affect vision? Do we have things that affect processing and intellectual ability? And so sort of making sure we have a wide representation of disabilities sort of representing the feedback, the PFAC. Um, Partnered with Service Excellence in last year, maybe year before, was sort of reviewing the message of the month and what we would want to see sort of from a health stream module for new hires, and then also annual training that we all also love to do a health stream. I have to do a health stream too. Probably not as extensive as your guys's, but it still is a wonderful thing to do. I do have to say, Katie and Crystal have made it much more streamlined. And so I don't even know how many hours it was before. I think now it's about 8 every year. And it now is very specific, sort of how volunteer function and sort of part of the family partner program. And so we sort of had a little input on that, not a huge amount. We've spent a bunch of time with My Health. I think partly because they are such a good partner, both with us and I think a bunch of other PFACs. And they really want to, okay, let's have the patient voice. Easiest way to have the patient voice is to come to a meeting, show us what they got. We're then able to, have you thought of this? Have you thought of that? So we've done a bunch of stuff with My Health and sort of increasing the accessibility, majority on the app, but also web version 2. And then sort of, I think the biggest thing last year that we did was, it was our first year for something on site. So we got started in 2021. So we've been Zoom the entire time, which I think is beneficial for some things, not beneficial for other. I think one thing it is beneficial for is we have a wide representation of not everyone who's 10 miles from Stanford, and so have a very siloed representation from a geographic standpoint. We have people on East Bay. We've at times have had people who I think were in Seattle. So it's sort of being on Zoom was beneficial. But then obviously people have to go on a site for appointments. And so last year we did something that we're calling a disability walk. And I think the next slide. Cool. And it essentially was just sort of a very rudimentary needs assessment. We were very focused on, because in the past years, we'd hear one thing about parking or another thing, or getting from the garage to an appointment. And sort of one of the biggest things that sort of was when I initially joined the PFAC is they don't necessarily focus on one specific issue. Although it sucks for people who end up having one specific issue and one bad experiences. I think everyone doesn't want a bad experience, but it's a very hard of, everyone has one bad experience at some point in their life. And so the PFACs focus on sort of if it's a one-time thing, we can't really focus on it. But if it's we keep hearing the same thing over and over again, like we were sort of talking about parking and sort of getting to a path of travel to the hospital after you park, we decided that enough of our members have had this issue. We're wanted to sort of figure out what we can do. So we, last September, went on site and basically walked around entrance of 500, did the crosswalk, went down to the garage, went over to from the ED to Blake Wilbur area and the drop off over there. And so I think our biggest thing that we have noticed, which highlighted here, I guess not highlighted because it's not yellow, but one of the biggest ones was someone who might be in a wheelchair. We had one person in a wheelchair and then one person who was visually impaired, so couldn't see at all. And then we had a couple other low vision, and then a bunch of us with mobility issues. But we did have someone in a wheelchair, and it's very hard to see someone in a wheelchair. if you're just driving down and not seeing it. So sort of how to make it be safer. And also for those who, like myself, have mobility issues, we wanted to make sure that we um, would have enough time to cross. I mean, it's only, I don't even know how, 10 yards or something. So it's not a huge distance, but for someone who does have mobility issues, it can be. And so how to get drivers to alert. And so we figured out that if there was a way to have flashers, which they actually had flashers a while ago, but they were needed a repair or something, so they replaced them and then never put the flashers back on. And the other biggest sort of thing that we noticed was sort of the bollard in the middle of the cross path is for 95% of people, even people in wheelchairs, are you can probably navigate around, but if you're in a wider wheelchair, then it can be difficult. Some of the electric wheelchairs have some heft to them. And so sort of thinking about, is that really necessary or not? Is it something that we can possibly change? So we recently, a couple meetings ago, met with a couple of the transportation managers to sort of discuss these key ones. And then they asked us a bunch of questions. We also talked about the golf cart call box. And so nothing has been done yet because obviously we just met with them and things take time. But sort of they were eager to sort of partner with us and engage with us about what can be done to sort of either get rid of the bollard or put flashers on. What can't they do? So sort of partnering with them is, I think, a big one because obviously it's great if we tell people what to do and they do it. That doesn't work for anything. So yeah, that was sort of I think our biggest project to date for the disabilities PFAC.
Thank you, Dylan. So I'm going to move along to engagement opportunities. If you remember from the beginning, I mentioned that there are two components to this program, PFACs being one, and the second component of our program are our engagement opportunities. So these are opportunities that actually happen separately from PFAC work. So anyone within Stanford Health Care can request to engage with our patient and family partner group. And if a group is considering bringing patient and family partners into their improvement work, but they're not quite sure how, we have a couple of recommendations on how they might engage. So first could be consultations. So getting feedback directly from patients and caregivers. It could be over phone, over email, in person. And you can talk about topics like a process improvement. Maybe you have ongoing projects that you're working on. Maybe you're changing some of your scripting or signage and you'd like to get some feedback from patients and caregivers. That's a great way to engage. The second might be inviting a patient or caregiver to participate in an ongoing work group. As Dylan mentioned, our patient and family partners are onboarded very similarly to employees. So they take all of our health stream trainings. They are informed about HIPAA and our code of conduct. So it's actually completely appropriate to incorporate this group into ongoing projects and work groups. You also might want to host a focus group where you're doing a deep dive into a problem, maybe getting patients and families to look at your data and help to interpret that data for you and give their perspective. You may even want to bring them in to hear from them about their perception of a problem, so conducting a root cause analysis. So these are just a couple of suggestions on how teams might engage with our patient and family partners. These are a few categories here that are most frequently requested for patient and family partner engagement. In 2024, we received about 50 of these engagement requests, and we'll give you a couple of examples. So for things like continuous improvement, we did have a group of patient and family partners that sat on an ongoing work group, which created a standard process for evaluating the ethical use of all proposed AI tools at Stanford. This is called HEAL AI. Our patient and family partners were really involved in that. And the goal of the assessment was to make sure that we are identifying potential ethical issues, bringing in the patient voice, and helping to make sure that we can make recommendations that would help avoid harm for patients. We also had patient and family partners review a variety of patient education videos for our health education engagement and promotion team. So they would review these videos, they would look at the content, the quality, the clarity, and provide their feedback on the videos before they were actually distributed to our patients. We also had patient and family partners invited to speak at a variety of events, including our monthly SMCI Care management rounds. We've done a couple panel conversations for things like medical students. So really, again, just providing that patient voice through motivational storytelling. We had a few of our patient and family partners contribute to a new video that was created to highlight the culture here at Stanford Health Care. And the members who were interviewed for this video, they shared their really deeply personal experiences as patients and how those experiences really shaped their lives and the lives of their family members. So that video, if you haven't had a chance to see it, it's on the SMCI Care intranet page. But it's a great video. It's also now shown to all of our new employees through their orientation process. So any new person coming into Stanford will get to hear from our patients that way. And then finally, in interviews, occasionally we'll have patient and family partners support our hiring process. So we'll actually invite them to sit on panel interviews to help us select new employees for the organization. So again, just a few examples of things that we have done. And I'm going to turn it back over to Dylan so he can talk about the work that he's done through these engagement opportunities.
So I had a select few, tried to sort of give a variety of lengths and commitment times for them. And so in no particular order, I think I did it by when these happened for me. So one of the earliest ones that I participated in was being a part of a work group that focused on the musculoskeletal team and triage, because obviously a lot of people go to the ED if they break a hand or if they have arthritis. Don't necessarily go to the ED for that, but might see their primary care first for it, and sort of how to help cut down sort of a bunch of the waiting time, because it can take a while to see specialists, regardless of what the issue is. And so sort of they wanted to focus how to streamline that. And is it important to have testing done beforehand or to wait until the specialist? So it was sort of a group of, I think, a couple ortho docs, rheumatologists, a couple primary care docs, and then myself as sort of the patient voice. Personally, I've had arthritis since I was 3. So I've dealt with a bunch of OT, PT. I basically have been doing consistently since I was probably 3 or 4. And so have seen a lot of specialists for other stuff. I have a connective tissue disorder that causes my joints to be loose and poor wound healing. So I sort of also have had a bunch of ortho surgeries. And so I had to do this. This was, I think, 4 or 5 meetings over probably the course of a fall. And so that's one way of sort of the work group aspect. Another one that sort of is a continual from September to February. It's interviewing med school applicants. So a couple of years ago, Katie sent out an email saying, hey, if anyone's interested in becoming interviewing med schools applicants for the multiple mini interviews, let me know. I thought it was interesting, primarily because I've dealt with a lot of doctors. So I sort of hopefully am good at figuring out, is someone a good candidate, especially also with having majority of my care at Stanford, sort of understand the Stanford message, so to say. And so for the past 2 years, I've been doing that. And I really enjoy it. It's a couple per month from September to February. Plan to do it next year also. And so that is another example of sort of a continual one that started off as I think it was one Zoom talk with the Enterprise Contact Center. Essentially the people who aren't in a specific clinic, but they answer the phones and set up appointments and stuff like that. And so they were looking at getting feedback about the after call surveys. And so ended up just being a one-time Zoom, 60 minutes, I think. Ended up talking to the person who was running that project a few more times about that specific one, but also I like to say I'm interesting. And so I ended up talking to her about a couple other sort of issues I have run into with the enterprise call system. Things like, since they don't know, they're not part of a clinic, so they don't sort of know how a clinic might work and response time. And so sort of seeing if there was a way to improve as a whole. So chat with her a little bit about that. And then ADA work group. So the bunch of letters are, it's that we ask because we care. Phase 3 is focused on inputting accessibility needs and disability access in Epic. And if you're going to an appointment, do you need help with something? Yes, I need a lower chair to transfer into, or I need to have it be wheelchair accessible. So I've been doing that since about November last year. Weekly meetings with sort of the key stakeholders. So we have Sarah Foad, who is sort of leading the ADA aspect of it, and sort of an ADA committee, so to say. And then Sarah Foad, and then Jacqueline Liu is doing the We Ask Because We Care initiative. So it's with her also, and then a couple other people from their teams. And we're right now in the infancy of it. But my role is to, I'm someone with lived experiences with disabilities, multiple of them. So sort of represent patients as a whole. And also to bring it back to the feedback and have it be, make sure they're up to date. And once we start, we're still in the infancy. It's probably going to be 3 or 4 years is my guess. But once we sort of start to do the implementation aspect, bring it back to the disability feedback, since I'm on it, may or may not be chair at that point, but bring it back, and then it's an easy source of back to sort of the PFACs of, hey, let's go, we want to know this. So let's go ask people with a bunch of disabilities what they think about it, get their feedback, and then bring it then back to improve sort of the We Ask Because We Care initiative. One of the things was we reviewed the message of the month that I mentioned earlier, and then also sort of what we want to see from a new hiring aspect. We had planned to do that, I think, this fiscal year, but things get delayed, which is always totally fine. But it still showed that, hey, we might as still do it. It's going to be important when they end up having the time to do it. But it also is important to sort of have it not just be stagnant and be like, oh, yeah, we'll do this in a year or two. Like, we were already talking about it, so we might as well talk, give our ideas. And so last one that I joined in, I think, January of this year, is I'm on the patient safety committee. So sort of able to use my experiences. I have 46 allergies, I think, at this point, most of them antibiotics. I also have a lot of surgeries. And with that, you're in a medically induced coma. And so I am not able to advocate for myself during that time. I'm very fortunate that I live in 2025. And what should be done before an anesthesiologist gives any sort of meds is scan them. And Epic does a bunch of red flags, since most of my ones are antibiotics, but also I basically take away most of the first line anesthetics they usually use, some second lines and some even third lines. And so I sort of luckily have never had a bad experience with an I shouldn't say that. I have not had a physician-induced bad experience with anesthesia. I've had other anesthesia complications, but nothing that was a patient safety event or even a near one. But with that, when sort of, I forget if this one, it got put out to everyone or if Katie specifically thought of me. I forget which one. But I've talked with her more about it, and started doing that in January. Really enjoy it, and sort of the last one is surveys. I've done a bunch of sort of one and done, not identifying myself. I might say I'm on a PFAC or I'm a patient family partner, but nothing that's follow up. And so, yeah, I enjoy doing the engagement stuff. If I had to pick PFAC stuff or engagement opportunities, I would go with a lawyer answer since my father is one, and Katie knows this very well since it's typical Dylan response. I would go probably engagement opportunities because I am able to then link majority of those back to either the disabilities PFAC or the emergency department PFAC. So yeah, so those are just a couple of the ones that I've done over the 5 years.
Great. Thank you, Dylan. All right. So as I mentioned before, anyone within Stanford Health Care can come to me and request to engage with patient and family partners. So how might you do that? If you'd like to connect with someone like Dylan or one of our other patient and family partners, all you need to do is reach out to me. So it's a very simple process. I can help you to draft or craft your request and figure out what might work best for your team and then recruit from our pool. And the way that you reach out to me is through email here. So you have our contact information. And with that, we will wrap it up and I will move on to questions.
Thank you so much, Katie and Dylan. And I just want to start with a round of applause. So if everyone could show their video or use the Zoom React to do a little applause, this was amazing. And I just want to thank you again, especially Dylan, for not only giving so much of your time in all the various engagement and PFAC activities that you do, but also being willing to come here today and share your experience and story with us. That was super impactful. And I'm just so appreciative that you were able to join. So thank you. I'm not seeing any questions in the chat yet, so I'll get started with the first one. And just thinking about, thinking about partners as patients, as partners, and engaging with them in quality improvement work. When should folks reach out to you? Should they reach out kind of really early on? They have the initial idea for their QI program that they're going to attempt. Should they wait till it's a little bit more firm idea? Tell me a little bit about what's the best time for them to reach out to you.
Sure. So I'll take this one, Dylan, if you don't mind. We always recommend as early in the process as possible. We find it makes the most sense so that people don't have to be caught up if you're bringing them on later on. We also like to avoid the feeling of bringing in a patient to check a box, right? We want to really incorporate them into the work that we're doing and the projects that we have. So in an ideal world, it would be as early as possible. Now, that doesn't mean you can't bring them in later on. Maybe you've decided that you're at a point where you really want consistent feedback and it's a little bit later in the process. We accept requests kind of at all points in your project. So yes, our recommendation is early, but anytime also works.
Awesome. Any questions, Sam? I'm seeing you're coming up.
Yes, thank you, Katie and Dylan, for an excellent presentation. And I hope many folks will be able to use this information and integrate it into their practices. It's interesting how you have certain PFACs that have focus on ED medicine, oncology. How does the institution determine what areas to focus on? And are there new areas that you would like to expand to? Kind of what's missing at SHC currently?
That's a great question. So any team is eligible to think about launching a PFAC. I think there are a lot of things that go into it. So we like to think about long-term. What is your vision? Have you done a needs analysis to decide how you want to or how you would like to incorporate patients into the work that you're doing? So as long as we have leadership support and buy-in for something like this, we can evaluate starting a council for any department. Some folks get a little bit nervous about the long-term commitment and committing resources like staff time. Sometimes we will ask, can you provide food for your meetings? And so there's a little bit of a financial commitment if you're looking to start a PFAC. But if you have that buy-in from your leadership and you have that support from your staff, and it's really important to your clinic, your department, your area, we encourage everyone to consider it and think about it. I'm happy to chat with anyone who is interested. So that's really how they come about. A lot of them were formed initially to support the build of new clinics or even our new hospital, our 500P hospital. Our founding PFAC was our initial PFAC that started in 2009. And that PFAC was really charged with helping us to build a new facility that was really patient-centered. So obviously that was a long-term project, but when we opened the hospital in 2019, they were able to kind of shift their focus. And so now they really focus on caregiver support across the organization. So they can flex, they can change. We have PFACs come and go and sunset when they're no longer needed. So it's a dynamic process. I think one area that I would love to see us kind of address in terms of a PFAC would be around equity. So I think that's an area we could definitely focus on. I think we could help bring in patients who could speak to their experiences in that area. So that would be one that I would like to see. Dylan, did I miss anything?
No, and I think sort of like going back to what the goal of the PFAC is, obviously it's to incorporate the patient voice into whatever aspect you want. Sometimes it's a bunch of positive stuff, and so they want to highlight that and sort of keep having positive things. I think one of the things like with the disability PFAC when we sort of got started was majority of people with some sort of any disability has had a bad healthcare experience, probably multiple healthcare experiences. So I think that's sort of a little unique for our PFAC of sort of that might be the origin, but that's not what we're about. Of sort of these are all our bad experiences, and they need to fix stuff. It's working with the institution, be it like for us, our staff advisor Kelly is on the revenue audit cycle or something like nothing that has to do with any disability type thing. There are other PFACs where their staff advisor is like for the heart transplant, it's probably someone within the heart transplant clinic, maybe be a physician, maybe be a nurse, maybe be a manager. So I think that's sort of, sort of thinking about how it will end up, especially the long-term goal. Like it'd be great if we could do a bunch of 1 or 2 year long sort of mini PFAC, so to say. But I think just logistically, from someone who doesn't have to deal with the logistics aspect of it, that would just be a very, very hard thing to sort of do to make sure that the quality is being spent at the right time.
Thank you both. Yeah. And that kind of brings me to a question kind of in the details, Katie, but thinking about the consultations that you offer and thinking about folks on this call who might be preparing for their next QI project. Is there any more information you could share about kind of the timeline? You know, they reach out to you about how long till they have a consultation. Is there a cost associated with that? What should they kind of have in mind when they do that initial reach out to you?
Yeah, sure. That's a great question. So we have a very short form we ask folks to fill out, and it just asks, you know, what department are you coming from? What is the purpose of your project? So we want to be able to share, you know, what are you hoping to do with the information? How are you going to engage? Is it going to be a one-on-one consultation? Will it be over Zoom, in person? How long will it be? So just some details we collect. There's no cost to any of this, so it's all free. So we ask you to fill out the form, and then if there are any questions after we see your form, we'll follow up and just kind of get some additional information. I'm also happy to set up short meetings with anyone who feels like talking it out might be helpful. So we can look at what might be best for that project. We have about 100 patient and family partners in our distribution list. So depending on if you're looking for someone with really specific experiences, you know, maybe you want to talk to someone who has been admitted to the emergency department within the last 6 months. So we have to narrow it down based on the criteria that you're looking for. So we can. A lot of our requests are more general, so they're willing to talk to anyone. So depending on what you're looking for, we do ask for around 3 weeks in terms of putting together the request and doing the recruitment for that. However, once we have the requests ready to go, I send it out. We usually get responses from our patient and family partners within, 48 hours. So it's a pretty quick turnaround time. Then we would kind of turn it over to the requesting team to set up the initial meeting or the consultation. We kind of leave it up to you to schedule that.
Awesome. Okay, great. And I see there's a question in the chat from Catherine Connors. So thanks so much, Catherine. Feel free to come off mute and add some additional comments to your comment. But I can also see, so the question is, I appreciate presenting to the PFAC before my health research messages. How often does a PFAC consult on research? And I see you're also here, Catherine.
Yeah, this is, oh, sorry, go ahead.
Oh, that's all. Just
That's
thank you.
of course, good question. We have been getting more requests to participate in research. It wasn't something that we did a lot of in the past, but I think it is coming up more and more, which I think is really interesting. So we've done some research, for example, with our health education and promotion team. I got that wrong, our HEAP team, helping to evaluate some of the videos that were kind of going out. So they did a research project. The radiology team, for some reason, does a lot of research, and they're always reaching out to get patient feedback. So it's definitely something we are interested in pursuing. A lot of our patient family partners have an interest in research. The one interesting part about this is that in some cases, research projects are funded, and so our patient and family partners could be offered compensation, which we love and we encourage. However, it puts us in a funny spot in terms of the fact that it's a volunteer program. So depending on whether or not the program or the research is compensated, we still are happy to help connect with our patient and family partners for those research projects. We might just say, here is a project that we heard of. If you're interested, we'd love you to reach out to the team. They wouldn't necessarily be able to count the hours for their volunteer work, but it's definitely something we help promote and help make those connections if we can, because we know it's so valuable and our patient and family partners are interested in that. So.
Awesome. We meet with study teams regularly to help with their participant engagement strategy for research. Can we share this as a resource to study teams? I don't want to have the PFAC be inundated with research requests.
No, please feel free to share it. We're happy to hear from anyone who's interested. So yes.
Awesome. There's also a community advisory board for clinical research funded by our CTSA. So we might want to think about comparing and contrasting the best forum given for a given research question. But this is wonderful to also have available. It was really helpful for us, as I mentioned in the chat, for our My Health messages.
Thank you.
Thank you.
And I will say on that, Katie is very, very, very good about and I encourage as early on in a project as you can, but either finding, hey, I have this X, Y, and Z. Most likely she knows either if it's a consultation, like one-off Zoom thing, she probably knows someone or a couple of people that sort of meet that criteria. She also goes to most of the PFAC meetings for the various. And so she's in the loop about what's going on and sort of able to then direct it. If it's better to be directed sort of to a PFAC setting, can direct it there or can do it through engagement opportunities. So I definitely, I appreciate it because it makes it easier for us to sort of be like, yeah, let's do something or not if sort of we have that buy-in with any department and sort of Katie's the good liaison for that.
Thanks, all, and thanks for the great question, Catherine. We have probably time for 2 quick questions or 1 longer question, but before that, I do just want to note, I put in the chat, we do have a great PDF that Katie shared with us about the Patient and Family Partnership Program that is hosted on the SMCI website in the toolkit. If you just search the website for patient, you'll see it comes up. It has a little bit more information in like a PDF form, links to the request form and Katie's team, also an email out to them. So if you're thinking about sharing this with some of your partners or your colleagues or anything, that's one way that you can share this information. And of course, this lecture as well will be hosted on the website at a later date. So those are some sharing opportunities. Are there any other questions that folks have? And feel free, you can put them in the chat. You can also just come off mute and just say it out loud if you would also like. So I'll stop talking for 1 sec and see if anyone wants to do that. If not, that is totally fine as well. I know we're all just digesting this amazing information and thinking about ways that we can engage our partners, our patient and family partners in our research and QI going forward. So we like to give people a few minutes to transition to their next meeting. So I'll go ahead and wrap us up. I just want to again say thank you so much to Katie and Dylan and to all our patient and family partners. We so appreciate you and the work you're doing. And yeah, hopefully you'll be hearing from a few of us on this call and folks that hear about it afterwards as well, to bring the patient partners in closer alignment with our QI work. So thank you, everyone.
Thank you for having us.
Awesome.